Welcome to The Vitals, Mount Sinai Health System's newest video podcast. I'm your host, Leslie Schlachter, a neurosurgery physician assistant here at the Mount Sinai Hospital. And today, we have a great show. We're going to be talking about the COVID pandemic, the 5-year anniversary. And I'm joined today by two guests. First, we have Dr. Joshua Hamburger, an associate professor of anesthesiology, perioperative and pain medicine at the Icahn School of Medicine. Thanks for being here.
Hi, thanks for having me.
Yeah. And my second guest is Dr. Eric Blutinger, an emergency medicine and public health specialist here at the Mount Sinai Hospital and an assistant professor of emergency medicine at the Icahn School at Mount Sinai. Thanks for being here.
Thanks for having me.
So, were you guys here during the pandemic?
Yes, that's right.
Yeah, you're like, if memory serves.
Exactly, this podcast right now.
It's a blur.
So we're going to talk about the pandemic and the 5-year anniversary. But before we get into it, so that our viewers kind of know who they're listening to, can you just both give a little bit of an overview of what do you do here at Mount Sinai? What does your day look like?
Sure. So even though my name is Joshua, I go by Zevi, Z-E-V-Y. And so in my role as an anesthesiologist, I actually care mostly for patients in the operating room, but my passion is women's health, and so I spend a lot of my time in the obstetric hospital. So I'm one of the associate directors of OB anesthesia. A lot of my day is taking care of people in pain during labor or C-sections or planning complex deliveries for them. But a lot of my job as an anesthesiologist is planning for things that don't necessarily happen. We're the warriors. And so our job is to think of contingency plans. What would happen if this happens? What would happen if that happens? And then build that plan out, which is one of the reasons why our department was tasked during the COVID-19 pandemic to step up.
That's great. Okay, thanks.
And my role at Mount Sinai has spanned across a few different domains, but primarily I'm still working clinically in the emergency department. I see a lot of patients from big to small who have come through a number of our different hospitals. Currently, I work at a few different sites, and throughout the pandemic, I was working primarily out of Mount Sinai Queens Hospital in Astoria, part of one of the first waves in the city. I also was part of really building up the virtual care platform during the pandemic, which I can get into a little bit later, but currently am very heavily involved on the tech innovation side of things, working still in emergency departments, and also help oversee as a medical director the utilization management, care management program through the population health division.
So that's like a perfect example of what people think when they think ER doctor, and you just break all of that. You're doing so much more.
Everyone does everything all at once, and I would say certainly the ER doctors are no exception to that.
So go back to the pandemic, those first days. I know we probably all try and block it out, and even we actually had a show recently where I didn't remember things until we started talking about it. So that might happen today. Go back to the first days. What was that like for you guys?
The first days of the pandemic, I'll be honest, it was a complete blur. I do remember.
Were you in Queens at this point?
I was still at Queens. I had finished residency about 5-6 months just prior to that. I was getting my feet wet as a first-year attending, just finished my boards, and remember being in the ER, getting week-to-week announcements with our department of screening certain patients for this thing called COVID. First, it was a small dot on a global map in Southeast Asia. Then it spanned to all of Asia a week later. Then it spanned to Europe. And I remember thinking, oh shit, this is spreading pretty quickly. I don't know when it's going to hit. And then finally, I believe it was the end of March where things just kind of exploded.
Yeah.
I also remember thinking it's so far away. What are the odds it's really going to take hold here where we have such a modern healthcare system? And then when I saw it hitting Italy, that's when we really started taking it seriously.
Did you guys have colleagues overseas that you were chatting with?
I didn't have colleagues. I was actually using Google Translate to look through the Italian newspapers at the time. I was working to try and build our care plan in the hospital. So we were setting up operating rooms to deal with the one-off patient who may have COVID. So I was working with the infectious disease specialties and our anesthesia department. We were teaching people how to don and doff. I know those right now, this feels like curse words. Don and doff PPE. And this was the beginning of March. And thinking this really looks like it's coming in our direction. And, a few of us in the departments were really trying to step up and help put other people at ease. And I remember one day I was donning and doffing in the operating room, teaching everyone, this is what we're going to do, this is how we're going to stay safe, we're going to avoid COVID. And then in the beginning of March, I got a cough and a cold and got COVID.
Oh my gosh.
So yeah, I mean, it was a present for my wife. She works at a high school where like we had, the patient zero, who probably was not patient zero, actually definitively was not patient zero in the States. And it spread from that neighborhood to this high school. And so, and on March, I remember
So you
March
probably
13th.
brought it to Mount Sinai.
Oh, definitively, it was me. I was the one. No, actually, at Mount Sinai, I was the one wearing the PPE, like in the beginning. And so, like, I was preparing, and then got it first. At first, I'm like, oh, this is embarrassing. Like, obviously,
You're
I wasn't
so
signing
devoted to
anything.
healthcare to see what it was like before everyone else.
It was actually a blessing, largely because back then we didn't know how bad it was, because Chinese weren't telling us anything. We had no details from them. And then in Europe, it was such a shock, as it was here when we first came here, that there wasn't any medical data. It was just these random opinions and a lot of newspaper articles. But like, we didn't know to be nervous. When I lost my smell and taste, I went on like Facebook to ask around, like, oh, I can't smell and taste. Is this a symptom? And someone wrote back, oh, you just have a sinus infection. Stop being such a baby. And I'm like, that didn't age well. And I found like Italian newspaper articles on it that this phenomenon is happening. I'm like, oh, this is how we could tell someone has COVID now.
Yeah.
Same thing happened in my department. So my boss, Josh Betterson, he's Italian. His wife is Italian. They have homes in Italy. They immediately got on the phone with their colleagues and were like, tell me everything you know. So a week or two before we stopped elective surgeries and kind of started shutting down, we had already started to shut down, because he was like, I know exactly what's going to happen. Yeah.
Yeah, I lived in Italy when I was a kid and have a passport and speak it. And I have a few colleagues in Italy. And at that time, I remember calling one of them. And the first thing he goes, Eric? I was like, see? And he goes, Mamma mia. And I remember thinking, what does that mean? And
This is not good.
Right. Everyone knows what Mamma mia means.
Yeah.
And then he said,
With the hands.
And he said, tutto è chiuso, meaning everything is closed. And I thought, oh man, if this is happening in Italy and we're just getting inklings of it now, I can't imagine a place like New York, what's going to happen in this city.
What were the biggest challenges, looking back, you might not even remember, but like, what were the biggest challenges or hurdles that you guys had in the ER?
There were a lot of them. I think one of the biggest challenges was lack of resources and supplies. We had a complete cutoff of information coming from elsewhere around the country and the world because of the communication channels that just weren't there. Social media.
What do you mean?
Like, we didn't have any peer-reviewed articles on how to deal with COVID. We had no guidance from professional societies or organizations on what to do as best practices. And when the state kind of waived our medical liability during that pandemic, it felt real, because I realized that we were really flying off the seat of our pants without any evidence and could do whatever we could do with what we had available. That was one. I think two was not having any information available to share with patients and their families. And when we had that no visitor policy and patients were frantically looking for solutions, which is what happens all the time in our day-to-day life, getting on the phone with crying family members, not being able to tell them anything about what we know about the virus, what to do about their families, loved ones, and not even letting them set foot in the door with a mask on, really painful.
Yeah. It was like, I even remember at times, because half of our department stayed on neurosurgery because people don't stop having like tumors and aneurysms and things. People don't stop having babies. But the other half went to work on COVID. And I would be happy if we could even like make a phone call to family some days.
Yeah.
Yeah.
Yeah, we were so busy. It was so busy all the time.
So you guys couldn't, so you said obstetric surgery, right? So this is like, that's not stopping.
So yes, obstetrics is one of the few divisions that had to just continue going.
Yeah.
And I do feel bad now for people who went through the birth of your child under such circumstances. Luckily, even though pregnancy was probably an independent risk factor for worse COVID, most of our patients did just fine. But I actually got pulled off of obstetrics pretty quickly by our leadership team to actually do other tests in the hospital once I came back after COVID. So I actually left that area.
So what was like a typical day like for you, not an obstetric?
Okay. So when I came back, we had a group of people who were pre-infected, and we volunteered to do kind of the riskier jobs, assuming immunity. Mm-hmm. So I looked at it that I'm lucky, I had COVID already. What are the odds I'm going to get it twice? What made coronavirus dangerous, because there's lots of coronaviruses out there, is it was the novel coronavirus.
Yeah.
But it wasn't novel for me anymore. So I joined the rapid response team to put all the breathing tubes in. I came to the ER to intubate patients frequently.
Wait, so hold on a second. So for the people listening, I want to, so RRT, rapid response, can you just quickly define what that is?
So when someone gets sick outside of the hospital, you call 911 and EMS comes and takes you to the emergency room where emergency room doctors take care of you. But what happens when you get really sick in the hospital? And sure, there's lots of doctors and nurses, but there's a specialized team of higher trained critical care, really emergency doctors in the hospital who come to bedside where you are in the hospital and then increase the level of care, which means give you access to extra oxygen, give you access to medicine to keep your blood pressure. Really, it's the beginning of the heroic measures to keep someone alive.
Okay.
And so Mount Sinai built this team maybe 6-7 years ago. And it's a mixture of critical care doctors, emergency medicine doctors, and some anesthesiologists as well as nurses, nurse practitioners, respiratory therapists. It's a team that can basically do kind of hit and runs. They go to an area, stabilize someone, figure out where they're going to go after they're stabilized, whether it's an ICU, an intensive care unit, or something a little bit less, but still an increased level of care, and then move on to the next call, whoever's there. And so during COVID, obviously during the initial pandemic, this team was on overdrive. They expanded drastically to cover everyone in the hospital because everyone was starting to deteriorate and get worse and sick and need these interventions.
And those are the people that were at higher risk. Alex Reynolds works with us, and she was on RRT right away, and she was like one of the first to get COVID. And she's like, "Well, we just have to get through it, and then we'll come back and do it again." Yeah.
That was the problem. Is like it was always a mentality of just get through this, keep pushing. But there was no end.
No.
And also one of the other areas I meant to mention too was the political stuff that was out there, and folks who didn't treat this virus seriously or thought it was all a hoax, or who were pushing non-evidence-based detrimental practices out into the public for those who weren't fortunate enough, like all of us sitting at this table, to know what was real and what's not. That was also really painful. And I think the emotional energy spent on fighting all of that was almost as overwhelming as the physical energy it took to get through it.
I mean, I want to push back a little bit on that because in the beginning, there was no evidence, like you said before, zero evidence. Mm-hmm. And we as doctors are so busy taking care of our patients, there was no communication to families, to patients, to anyone.
Right.
And so there was kind of a party line of what worked or not. But now looking back, a lot of that was wrong.
Yeah, but
so
I think
we got very
right.
angry at people and created a them versus us mentality, which I think actually hurt us significantly in the long run in terms of trust in physicians and nurses by saying they don't know any better, we know best, when in reality we didn't know up from down at that point in time, at least in the beginning of this, the time of this surge. Maybe later you can have a little bit more information, but at that point, we had nothing.
Totally agree. I would just say that the line was easily crossed when folks who didn't have any expertise or who weren't seeing it were kind of downplaying the level of crisis mode that we needed to be in to stay afloat as a society. That's where the frustration kind of brewed over. And I think New York City shot itself in the foot inherently for the way it's built and constructed. The idea of sending someone home with a virus to self-isolate with all your family members who may not be infected just propagated this thing. And I do look back with a lot of regrets. And I think one of the regrets is the public health lack of focus we had collectively, not pointing any fingers, but like our decisions on what we were guiding patients and telling them to do, a bit controversial in hindsight.
So knowing what you know now, what would those recommend, like now that you have this information, what would it be? What would the recommendations be?
Honestly, what the Chinese did, where if you were infected with the virus, to self-isolate and to self-contain, and perhaps in a hospital-based setting, there is an argument to be had that was a potential solution to prevent viral spread in the community. Mm-hmm. And I was in Queens, where there are a lot of families that all live under one roof. It spread like wildfire. And I think part of it I take responsibility for, if I'm being honest, because there were a number of patients who were infected. And I told them, isolate in your home while we figure out what's going on. We don't have any bed space in this hospital. Yeah. But part of it was going back to my original point of supply constraints. We just didn't have the hospital capacity. Right. We didn't have the availability.
And you can't control their home life either. Like,
no.
What does it look like? How many people are in like a studio or a one bedroom?
Right.
It works for people who have homes. Like individual family homes. But like you're saying, if there's multi-generational families living in apartment buildings, or if the population density is tight, I would probably communicate a little bit more humility. Instead of do this. This is what we know so far. We don't know a lot. This seems to be helping. This may not be helpful, but this is what we have. And I think that may have built more trust. And then I think people would have listened to the isolation orders a little bit better if it wasn't so top down, pushed down, where the expert class listened to us. Even though at this point we were the experts, we were flying blind a little bit.
How did you guys handle stress during that time? Were you just like on autopilot or?
No, I think so. What I ended up doing when I came back to the hospital, so I joined the rapid response team. It was all voluntary, this group of us. In our department, our chairperson is a critical care doctor. His name is Andy Leibowitz. He really was 2 steps ahead of most other people on this pandemic. He broke our department into these little teams. So if one team got infected, we can quickly fill gaps in other places. He let people to a degree kind of pick where they want to end up in the hospital. And our department ended up actually managing many of the ICUs while the other ICUs got up to speed. So we opened up all of our recovery rooms to different types of ICUs, and our attending physicians and PAs and resident physicians really stepped up to manage these critically ill patients while the other ICUs were being built. And so the team that I was on, the rapid response team, we also had an innovation team where we were trying to figure out what kind of PPE to build, use, and how we could split ventilators when things got really bad. But I was in the hospital for maybe 30 days, 35 days straight. I think the fact that I was part of a team and I had a leader who was in the building with me helped motivate me to come back each and every day.
Yeah.
But the team that I was with, the group of anesthesiologists and nurses and other people and criticalists and infectious disease doctors, I think that's what motivated me to push forward. I felt I was part of something bigger than myself in that moment.
Did you ever burn out? Like truly burn out?
Not from this.
Yeah. What about you?
Oh yeah.
Yeah?
Oh yeah.
Tell us about it if you can.
My half-life as an emergency physician was cut drastically from the pandemic.
My half-life.
My half-life. I feel like I've not become what we call sometimes crispy. I love what I do, and I love taking care of patients, and I will always continue to do that until I'm a crotchety old man. But I feel way more tired than I ever imagined just 5-6 years out of training. I think part of what's blunted that blow, though, has been part of Sinai being part of an amazing team, to your point. It's been journaling. I talked to a New York Times reporter during the pandemic, Leslie Bloom, who I'm still in touch with, and the one thing she said is, Eric, just keep a journal, take videos, take photos, document what you're seeing because it's going to be part of history. So to me, inherently, I felt this sense of purpose that you mentioned earlier, and I went running a lot. Mm-hmm. I remember
Were you
running,
a runner before?
No, but I just became one.
Okay.
A makeshift run-of-the-mill one, running down Fifth Avenue, no one on the streets,
Yep.
No cars, no dogs, no people. It was crazy to be living in Manhattan and to be commuting where no one was on the subway cars. So there was that. But I think part of the other struggle I had is a lot of the stress I had was even followed me outside of work because my wife's mom and my mother-in-law was in the ICU for 6 months with COVID, was a case study. She failed all the treatments. Thank God she survived based off of a miracle cure, which was a transfusion from her husband eventually who had antibodies. But that was also keeping me up at night. So I wasn't getting a lot of sleep and I felt like it definitely burned me out.
Do you think now in hindsight that you know what that looks like and feels like and you, like by default for life, had to develop coping mechanisms? That's something that you learned from and have resilience from now?
It's a great question. I think learning about attrition and understanding yourself is pivotal to a sustainable career in medicine as a whole. Healthcare is never going to be in the clear, I'm going to argue.
Right.
It's always going to be a crisis to manage. So finding ways of coping with those challenges is important. And I think it's set my outlook on life and health moving forward. But every couple years, the crisis seems to pivot. And while we did deal with COVID 5-6 years ago, there's going to be, and there still are, a lot of crises out there that in different ways we're going to have to learn how to adapt.
So from what you guys learned during COVID, how has that evolved your jobs now? Like, did you just kind of revert to what things were before, or did it kind of change how you practice medicine?
So I was actually shocked by how quickly things did get back to normal. Even though, I mean, COVID, even though it was 5 years ago, it kind of feels like it was 25 years ago.
It does.
Like you're aged. But like, our job in healthcare is always crisis. There's always an emergency happening. But like we were there when the building was literally like on fire, like the sky is falling. And so like you take a deep breath and like, I've seen worse. Okay, keep going. But after it was all over, and I'm like, okay, let's build a new playbook for next time. Let's our last playbook didn't really work at all, so let's actually have a new playbook. And we're just like burnt out. We can't even think about this.
Wait, but did it not really work? Did you call it a failure?
So I think
because you said our playbook didn't really work.
Yeah, so I don't think anything was actually from a playbook. A lot of what we did was it was kind of learning on the fly. There were pandemic playbooks like in government and things like, and this is where a lot of the isolation of things came from. But I didn't see a centralized, did you notice any centralized guidance for the most part? Because a lot of times we get this thing, steroids are bad, and then 5 minutes of steroids are good, or like 6 feet, or
we would like literally walk to other ICUs and be like, oh, that's a good idea.
That will help you. Prone people, like everything was just back and forth.
But proning, I think, was a good example
100%.
Of like a playbook that was being made on the fly.
But steroids, a lot of it was on the fly.
Yes.
Yeah,
like,
so it wasn't
a book. It was, let's try this, see what happens, and then we'd communicate internally. We'd have these groups in the hospital and say, this is what's working for our patients. Let's start proning, and then we'd build this team to go and prone people.
And we knew not to drink bleach.
Huh?
Yes. We knew not to drink bleach. Right? That was a playbook.
That was definitely a playbook, for sure.
On the fly.
We knew that masks were good. I hope.
So when you were talking in the beginning about like, there are people out there that just like the naysayers or whatever. One of my memories from the beginning, and it lasted a while, was like the people that refused to wear masks. I could not wrap my head around that.
That was me in the beginning. And still.
Really?
Tell me more about that, because I was so frustrated by that.
I'm going to get fired. So I work in peri-op, and we wear masks in the operating room. If you want to look at data for preventing even just wound infections for a surgeon wearing a surgical mask, not an N95 mask, a surgical mask in the field, good luck finding some of that data.
Yeah.
It doesn't exist. Even sweating in the field, like dropping droplets into, like that may be the only thing that the hat and the mask may actually prevent, even though these are all the rules and taken as law of the land. And to me, N95 protection it's an airborne virus. It's the only thing that's actually going to work. I think that demanding masking led to a false sense of safety amongst ill patients and people who thought that if I did this, I'll be totally safe from the virus. I think it was a total false sense of safety, and I think it maybe even made people worse off, because you'd mask with grandma and grandpa, and little kids masking with grandma and grandpa is not going to prevent the spread at all.
So you think
but
that
I think
the
they were
public...
pretty clear. Like, I feel like the news was pretty clear saying it's not going to prevent it. It's just going to reduce.
If you're ill, it prevents splatter, just like a salad guard.
But let me push back for a second. Do you think that folks who are not in hospitals or clinics, but are just doing their day-to-day thing in the world out there who don't know anything about medicine, someone wearing a mask versus someone not wearing a mask, do you think that the one wearing a mask helped contain at least a little bit of the spread?
Unless they were ill themselves, no. I don't think it provided any personal protection. I think it prevented the spread. If you're coughing, the droplets don't go as far, for sure. You're sneezing. Yes, so if someone is ill, yes. But unless you're wearing a system that actually catches enough of a small, the mask has to be small enough to actually contain. It's just the droplets you're preventing, not the airborne puff that comes out with the cough. So I think it maybe shortened the distance.
I'm willing to accept this, because he's a healthcare practitioner and anesthesiologist. But for the random people that are not in healthcare that are like, masks, I was not into that. I was like, just put on a mask. We don't know.
It was almost a sense of solidarity.
Yeah.
I mean, that again, I think it's a you're with us or against us in healthcare, and I think that totally undermined our efforts. Even in research, you can't even research mask efficacy, because if you had a negative study, you never get published, or if you had a positive study, they were few and far in between.
I see where you're coming from.
Yeah.
I think everything's a risk benefit, generally. And the risk of wearing a mask, to me, did not outweigh the benefit of potentially stopping more spread for situations you just outlined. So I think, I'm with you. I think wearing a surgical mask was not asking for a lot for someone out there who may be able to protect the 90-year-old grandma walking down Central Park South.
Who we've just learned maybe.
Who we
not
just learned.
definitely, right?
Yeah, maybe. And that's, I think, those are the memories that really bothered me when I think back to that era, is seeing this wanton neglectfulness for some of the basic health measures that were at least being advised, not enforced, but advised. And we were all kind of in this pandemic together. So I'll stop there, but I think a lot of this.
I agree. I mean, I'm a surgical PA. I wear like he said, and I understand what he's saying, but in an OR, you wear scrubs, a mask, and a hat, and then to hear all these people be like, I'm not wearing a mask. And it's like, I wear a mask every single day for everyone to be safe. Like, can't we just do this for a little while?
But trying to put a mask on your 2-year-old kid so they can go outside. No, and a lot of kids have learning disabilities. Now, a lot of kids need speech therapy and a lot of other issues. Like, the blanket statements, I don't think were very helpful. I think targeted therapy would have been a lot more useful. So having grandma and grandpa, if you're going to visit them, put on the mask. But jogging outside when you're running on Fifth Avenue with your mask, I don't think, that is just like, it's wearing something to show you're on the right team more than thinking about what the risk profile is.
Did you wear a mask running on Fifth Avenue?
No. So maybe
Really?
I'm part. No.
Because I was walking outside, I remember in May, and I was walking my wife outside in Central Park, and someone yelled at us, "Why are you wearing a mask?" I'm like, "We're
outside."
outside.
I
and
know.
all
But
this
good
stuff.
luck with targeted therapy when we are still trying to convince people that vaccines work. Good luck. Like there is this basic degree of non-acceptance for what to me feels like very obvious guidance, generally speaking, in society. So I agree with you. Perfect world. It should be targeted. It should be all tailored. It's never a one size fits all. We know that, especially in healthcare. I just think that there has to be some basic level of understanding for some of the foundational principles that occurred during the pandemic at that time. And some of that just wasn't followed on a basic level, which made it hard. So we're in agreement. I just think it's a different way of skinning the cat.
Yeah, I'm not saying masks don't work at all, because I wear a mask at work every single day, and especially with flu coming up, it's droplet. It helps with that, but I still feel that it was kind of you're with us or against us mentality. And in all of medicine, we use an informed consent model where we give patients some semblance of autonomy. Telling them everyone has to do this because we say so is very paternalistic, and people don't respond well to that. Like, even in your job now, you say, this is my recommendation, this is what I think I should do. If they don't do that, I mean, is your mentality to get angry at them?
No.
We don't do this
not at
anywhere
all.
else in medicine where
No,
we
I
get
agree.
angry at them for not agreeing with us. But during the pandemic, healthcare providers were just angry at everyone else, and it came off as angry, and I think that just turned so many people off. So I think we had a lot more people masking especially when masking was necessary. If you're going to a nursing home or you're going to a high risk situation, especially in those or tight where everyone's kind of packed together potentially. And I think we ended up having the opposite effect of what was intended. So that's my main point.
Yeah. I think about, you can't yell into a movie theater and yell fire. You're supposed to be wearing your seatbelts when you drive down the highway. There are guidelines and paternalistic recommendations that are bestowed upon the public to keep everyone else safe. So it's a balancing act. It's a fine line.
That's it for the first half of this Vitals episode. To check out the second half of the episode and to hear the Vitals regularly, subscribe to the Mount Sinai Health System on YouTube and to the Vitals on Apple Podcasts, Spotify, or wherever you get your podcasts.